Okay, hello, and thank you for joining us in this video today. This is Dr. Helene Nguyen from New Jersey, Hackettstown, New Jersey, and my name is Dr. Christina Jansen, and I'm a podiatrist and I practice in Midtown Manhattan. So we thought it'd be a good idea to have a discussion on how to treat, in different methods, foot pain. Dr. Nguyen is a specialist in minimally invasive surgery, and I am a specialist in biomechanics or conservative treatments for foot pain. So thank you very much for coming to join me today.
Well, thank you, Christina, for having me joining you in very nice, beautiful beach house in South Jersey. Our life is very busy with patient care, so, this opportunity come by, and I don't want to miss out this opportunity to get together with Dr. Jansen to talk about foot health. And since this April month is a National Foot Health Awareness, so I think it's a perfect time for us to get together to educate the public. You're right. Hey, you know what? We all learn something. We're so busy with patients.
Well, so busy, yeah. We're both so busy. So we really had to carve out our time in order to do this.
Right. And to us, every day is a foot health awareness.
Yes,
right?
every day. So
every day.
We don't have a particular month, but.
With that, we would like to share with public, the non-surgical solution and surgical solutions for any foot health, foot deformities. And, I think that you kind of have both of us here, the best of both worlds of conservative care and surgical care. So, so I think that's a great chance or great opportunity to educate the patient.
Yeah, because people go online and they say, my foot is killing me now for a while, and you go online to see what kind of solutions are out there.
And Dr. Google and Dr. YouTube?
Yeah. So you see podiatrist, what is a podiatrist? And orthopedist and physiatrists and physical therapists all treating foot pain, so you don't really know what in the world to do. There's gadgets you can buy for your foot pain, should you just be your own doctor? So it's very difficult. So I thought that it would be a good idea to do a discussion that reminds me of the first year of podiatry school, Introduction to Podiatry 101. And one of the first lectures we had as young, nervous students was, let's divide treatment plan into conservative treatments and surgical treatments so we could decide how to best approach a certain foot condition.
So Christina, what I did, the same thing, we got a similar training. I got trained more focused on surgical option, and I believe that we'll talk about one of our conversation. You also trained to do procedure and surgery very aggressively as well, right?
Yes.
So we always start at some point, but somehow our path is kind of like our career path is leading to different, because we identify that what is more important for our personal gratification as well as helping patient. I think that is more important as we become, we practicing more, we see more patient and how we can help with their conditions. So my path is I start out with traditional surgical training, and now I'm taking my path into minimal invasive approach. And that is one of the approach that I don't think a lot of general public aware of, that it is a solution. Surgical solution to correct foot and ankle deformity with no hardware.
Yeah, can you explain what it is? Minimally invasive surgery. I don't think a lot of people have even heard of it.
Yeah, so I didn't even know about that until I got to my training. One of the lucky thing that I found that I rotate through a plastic surgeon rotation, and I saw her how she corrects certain things. To me at that time, now 18 years ago, 19 years ago now, but that is the first encounter I have about minimal invasive approach, but to non-podiatry setting.
Yeah.
And it's just amazing. And when we graduate, we so influenced by hardware company, pharmaceutical is pushing using hardware as a fixation to correct bunion, hematomas, and all other medical.
That's how I learned. I was originally a surgical resident.
Yes.
And in those days, because I'm older than you, we did open surgery only. We made very large incisions, 3 or 4 inches in the poor little foot. And then you would cut soft tissue to get to the bone and make your bone cut. But because the soft tissue was cut, the cut was very unstable, so it had to be stabilized with hardware, with K-wire,
And
pins, screws,
afterward.
monofilament wires,
Yes.
plates, you name it, we put metal in there. You know, we had to because we'd made such a big incision and cut all the soft tissue support away. So,
Right.
and it's still really, that's the majority of foot surgery is done like that right now.
And it's still carrying through. The traditional approach is still going through, and that is what set minimal invasive techniques apart. Is that through a very tiny incisions, as little. How I do is I tell patient it's a poke incision. It's a 2 millimeter incision on
Wow,
the skin.
that's small.
And then that will be able to get my instrument in correcting the deformity without using any of hardware. And the patient will be able to walk the same day.
Okay.
And that procedure.
That wasn't true when we were doing surgery back 30
No,
years ago.
Yeah, we had to get the patient on some sort of crutches or weight bearing.
Oh, they couldn't put any weight on the foot.
Yeah,
no.
yeah, there's no weight bearing. So, with this minimal invasive technique, that we'll be able to get the patient walk on the same day. The procedure can be done in the office because of just local anesthesia. The patient doesn't have to go through sedation at all. So literally just a calming medication for the patient to sit still for about an hour, and patient get up, all the dressing and all the strapping be able to put in place, and patient will be walk out with their family, and just like walking through the whole recovery process. And that is the difference between minimal invasive approach versus the traditional approach.
I think you're probably one of the top 10 minimally invasive surgeons in the United States.
Yeah,
I mean, looking at the internet, I would say,
Well, I
you're
try,
way up there.
I try to be humble about this because, there's so many ways to help patient. And I think my way of helping patient is provide the solution for the patient. With a traditional surgical technique on foot and ankle surgery, that we have an age limitation. So with this minimal approach, I'll be able to help the patient who older. And that's when their ability of walking, be more mobile and be active is so important compared to the younger generations. So I'll be able to do a bunion, a hematoma procedure or correction to the patient as old as 94, 96. I mean, can we do that under traditional approach?
No chance.
Exactly.
You can't afford them not walking.
We
for
can.
2 or 3 months.
Yes. So,
You can't,
but beside that, I'll talk about the minimal or surgical interventions. We also want to know about what are the options before the patient think about surgery. And I think that's when I would like to pick on Dr. Jensen's brain here. That she's very. I would say she is genius in terms of biomechanic and evaluations, and offer the patient the solution, a non-surgical solution. So for those patients who not a surgical candidate will still be able to use, but also prevent the patient to come to me for the surgical intervention. So I think that is a very important role and hope.
Yeah.
So Dr. Jensen, if you don't mind, just briefly share with us and share with the public here with the biomechanical evaluation, and how would you look at a patient foot deformity? How will you evaluate, and how is your treatment plan would be? If you can share with.
Well, I'll tell you a little bit about my history, because I find your history really interesting, that you were first exposed to your type of surgery from a plastic surgeon. My experience was that I had a very high-powered surgical residency in New York City, so I rotated through 10, 11, 12 hospitals in the city, did a lot of open surgery, a lot of ER work, did hundreds and hundreds of cases. And then, so in my private practice, I had a surgical practice. I did traditional open surgery. And then, just for some extra money, I got a job with an older podiatrist who was making orthotics by hand. And as a matter of fact, I was so ashamed that I was taking this rinky-dink job. I didn't even tell him I was a podiatrist in the beginning. But he paid a little bit of extra money, and he taught me how to make orthotics by hand. And he had gone to podiatry school in the 40s, believe it or not. And just to date myself, this is like 30 years ago. So he was still making orthotics the old-fashioned way that they used to do it in 1940, 1950, which was to make a plaster of Paris model of the patient's foot and then layer materials on it, layer by layer, and then grind it down, add posting, grind it again. Very labor-intensive work. And at the time, it was just for extra money, and I was doing a lot of surgery, during the week. And but little by little, I really enjoyed it. It was very artistic. I felt like I could really expose my creative side. I enjoyed it very much. And I got very good results with the handmade orthotic, with the plaster of Paris cast. And then little by little, I just started doing more orthotics, splints. The old doctor had taught me how to make latex shields and spacers and splints and all kinds of conservative treatment. And then podiatrists really stopped making orthotics by hand in their office, and they started using factories. They could get orthotics very inexpensive, $50, $60, and meanwhile I was using $300 worth of materials to make orthotics. Mm-hmm. But, so of course people abandoned the expensive, labor-intensive way to make orthotics, but I really enjoyed it, and I got very good results by doing things in a very tedious manner, very sophisticated manner. And then I began to travel all over the place, learning about biomechanics, learning about orthotics. I went to Oklahoma, I went to Atlanta, Georgia. I just kept traveling and picking people's brains about how they made orthotics. I did it in Europe. I learned in Holland from a biomechanist. Anywhere somebody was making something, I went there and bothered them and spent time with them. So that's how I kept adding to my knowledge of biomechanics. And then really every podiatrist either had retired, the older podiatrists had passed away, until little by little, I believe I'm the only podiatrist left on the East Coast, maybe.
Okay.
I think there's one or two other podiatrists in the United States that do what I do. So now I have given up surgery. I have a conservative method only of treating patients. So, and that's now the audience can see certainly how you and I have very different practices, because you have a very sophisticated, special way of treating patients, and so do I, which is actually kind of dramatically different.
And I think that we, kind of like what we start out with a conversation, we start from surgical training. And I think that you have that knowledge about the surgical approach.
I think that helps me.
Yes, and it's helped you to guide the patient or be able to provide the patient a solution, non-surgical, or even after surgery, you can still make orthotic. Surgery is not the end. Surgery can be just a beginning of their new feet. They still need to maintain that, and that's when, you can also help the patient on that, transition as well, for them to get back to their walking and prevent any further deformity may happen, even after surgery.
And here's a question that people might want to ask me, is they might ask me, do I ever send a patient out for surgery? Because it's okay if I don't do it. But certainly there are situations where the patient does need surgery. I would say one situation is when the foot no longer functions properly. For example, hallux rigidus means that the big toe joint doesn't move anymore. Right. I send patients for surgery because if that joint were to flex again through surgery, I can do a better job with the orthotics. So I do refer patients for foot surgery.
And I do also, for me as a surgeon, if after a procedure, and if we know that is this patient like for a bunion deformity. Bunion deformity is when the big toe have a big bump. And it's affecting the patient when they wear footwear, rubbing inside of their shoes. And that is the majority of my patients coming in. They haven't gone to any conservative option, but the pain is so severe that they not be able to tolerate to walk on.
That's a very good point. I would say that's another time when I do send the patient for surgery, because the joint, they're in so much pain, that surgery is a very good option at that point.
Right. So how I usually tell patients, yes, I can take the pain away. I can remove the bump. I can realign the joint. But in order for the patient to prevent this deformity from happening, I will send to Dr. Jensen and refer out for orthotics. Yes. So because that any foot and ankle deformity mostly is coming from the faulty foot structure, and that's we have to correct the underlying problem. Surgery is only take away the pain immediately, and it realign to a proper way because it's been compensated for so long. But it's not really correct the underlying problems, right? I mean, that is something that most of the time, most of my patients, I refer to orthotics afterward. It's just for support. For the younger patients, they're going to be very active. If for older patients, something like accommodating, that would be sufficient enough. But it's for the accommodating with the, with the biomechanical.
That's interesting. I have a question for you, Dr. Nguyen. Do you ever do surgery sort of for cosmetic reasons? Because that is where you would have me. The foot, if I see someone with a tremendous bunion, they say to me, I can't wear sandals. My feet look so ugly. I don't want my grandchildren to see my feet. So, that's a weakness in a conservative approach. I can't change the way the feet look. So do you ever have patients that come in and their interest is cosmetic?
Yes, I do. I do have many, especially when patients follow me through social media. They see the results afterwards, so they're really impressed with that. How I tell the patients is that there's two pain components when the patient comes to see us, to see the doctor, right? Whether it's a physical pain, which is really that deformity, foot and ankle deformity really bother them with pain-wise. The other part is emotional pain. So I have the younger, 17 years old. Okay. Very severe bunion. Does she really have pain, like physically? No. But when she go to the beach and she wears sandal, all her friends saw her toe cross over.
Yeah, not even that. They go over to visit their girlfriends and they take their shoes off and they're eating popcorn and
yes.
hiding their feet under the rug.
And that's when the emotional pain. At 17 years old, you be very cautious, subconscious about your body, and that is something if we be able to, not even the physical pain, but like emotional pain at that age is so important because that is like bring up the self-confidence, and that's something. I think conservative option is it kind of like not really taking care of that part of it. Not really address the patient concern at that level. So that's when the procedures coming in, and with minimal invasive approach that we can do that with like incision as little at 2 millimeters. So
I have seen patients that came in and said, I'm thinking about surgery, but I'm here for a second opinion, and surgery is very expensive, and I'm also frightened, so I'm afraid to have foot surgery because my mother had foot surgery 20 years ago, and it was so painful. So, that's one of the reasons why a patient will see me and want conservative care.
I do. I have patients coming in with all different concerns because I think that foot surgery is so popular. They know their family have one, been through it, their friend have been through it, and a friend of a friend have been through it, and it's horrible pain, like I think that the idea of foot surgery is not pleasant. Any type of like surgery is not pleasant, and the fear of uncertainty, we don't know what could happen, and that's not pleasant.
People put it off.
That's why we tendency to put it off to get the care for. And with the minimal invasive approach, I'd be able to share the patient. I show the patient a before and after picture and share with the patient what we can do to help. The patient virtually have no downtime. I have patient, I do procedure on Friday, I get back to work on Monday.
Wow. Okay, that's never going to happen with open surgery.
Right, exactly. So, and that is the solutions out there. And, any surgery, I tell patients, don't think that having surgery as the end. It's the beginning of their new feet. And I think with that mindset is be able to put the patient at different level of care for their body. And yes, about pain, right? I also address the patient about pain as an issue for surgery. But it's the pain that they have right now, less than or more than if they think about having surgery.